Methicillin-resistant Staphylococcus aureus, or MRSA, is probably the most common bacteria we encounter in critical care. We know it as a staph infection that can affect different parts of the body, most often the skin. Now, this usually presents as cellulitis or an abscess, or both. Now, MRSA can also cause pneumonia, bloodstream infections, or surgical site infections, and if left untreated, it can progress to sepsis, which we'll discuss in a moment. Now, anyone can get MRSA, but your risk is going to be increased in crowded areas or if there's skin-to-skin contact and the sharing of equipment or supplies. And if the skin is broken, such as with any abrasion or incision, the risk for MRSA infection is going to be the highest. Now, it's also risk factors increase in the community, so athletes, daycare centers, military personnel in close quarters like barracks, sharing of towels or razors that have come in contact with infected skin, these are going to be the highest risk for MRSA infections. Also, IV drug users have been found to be 16 times more likely to develop a staph infection. Now, approximately 53% of patients in hospitals carry MRSA in the nose or their skin. We know this is colonization. So, hospital inpatients or surgical areas and those with invasive medical devices are going to have the highest risk for MRSA infection. Now, as far as symptoms, MRSA infections are going to depend on the part of the body affected. So for skin infections, most are going to start off looking like a spider bite and progress as warm, red, painful, swollen, and they're often going to have purulent drainage as well as a fever. And the diagnosis is going to involve early identification and prevention. You can't determine a MRSA infection without lab studies such as a wound, blood, or sputum culture. And then the treatment is going to depend on the severity, the location, and if there's purulent drainage or exudate involved. So for skin infections such as cellulitis, in the absence of purulent drainage, current recommendations are going to be for empiric antibiotic therapy. Now, some common options are going to include cefazolin for IV or cephalexin PO. And for more severe infections with the risk for sepsis, or if there's purulent drainage present, then an incision and drainage, or IND, is usually performed. The wound is going to be cultured, and broad-spectrum antibiotics like Vancomycin IV are going to be administered in addition to oral antibiotics. Now, you won't be tested specifically on the different antibiotics, but you do need to know that they're part of the treatment regimen for MDROs.